This is a general question and answer session. I've got a couple of questions still on cards, which we will deal with. I've got the whole panel or what's left of the panel here to answer questions. So if there's any questions from the floor, if you can raise your hands and Ruth will come round with the microphone. While people are thinking, I'll maybe start asking a couple of questions that have been handed to me. And we'll take things from there, but we will certainly be finished by 4:30. So the first question, and this is whoever wants to answer this, so why do some patients have a bone marrow biopsy taken and others don't? What is the benefit of the bone marrow biopsy? And then the second part of the question is, what is the impact of being diagnosed with a mutation? Does this change how CML acts?
Well, people do different things. The latest draft of the guidelines is going to recommend a bone marrow diagnosis, but not everybody has done that since PCR has become so mainstream. But I think there is no doubt not everybody does exactly the same thing with bone marrows, but the guideline recommendation will be a bone marrow diagnosis.
So my aspect with that is that you have to have a bone marrow diagnosis because we do need to know the phase of the disease and we do need to know the cytogenetic abnormalities. So I would say everyone needs a bone marrow diagnosis. Richard may say differently, but we don't need any bone marrows for routine monitoring. So in the old days we used to do this every 3 months, and then sometimes we used to do this once a year just to make sure that you have a complete cytogenetic response. But there is no need for that. The only time you need to do a bone marrow is if you can't interpret the PCR, if your bloods are changing, so they're falling and the doctor doesn't know why, your PCR is great, but your counts are falling, or it's something that they cannot explain because you go to the bone marrow, which is the factory which produces the blood. And you can find all sorts of things in the bone marrow if the blood is not behaving as we would expect and the CML is fine. One is to find out some additional chromosomal changes which are not Philadelphia negative, and sometimes other conditions go along with CML. So no routine bone marrows are to be recommended, and I think that needs to be translated into the general acceptance of how to monitor CML. So that's bone marrows. Richard, anything on bone marrows?
I agree. Nothing to add.
Okay,
And
I
mutation.
Okay. Yeah, the mutations.
Mutations at diagnosis, so the guidelines would say do them if you're in advanced phase. We don't do them at all at presentation because there are a soup of mutations, but the only clinically relevant ones are when you are not responding and you need to find out if you are resistant, because all the other ones at presentation tend not to be significant.
And the other question I've got here is there any evidence or research into why patients don't have a satisfactory response to imatinib or second and third generation TKIs?
Best place to answer that.
Okay, so there's lots of different potential reasons why patients might not respond. So they might have a B-cerebral kinase domain mutation, as Dragana has already mentioned. There might be an issue around about the levels of drugs getting into the cells. So there's proteins on the surface of cells that can pump drugs in and out of the cells. So that might mean that a drug level might be low or high within the cells. For people maybe on other medications that might interfere with the drugs, it would always be important to review other medications people are on to make sure they're not on something else that might be interfering with the action of the drugs. But we think that the main reason why people don't respond or develop resistance is because of cells called CML stem cells within the bone marrow. And we know that these CML stem cells are not particularly sensitive to drugs such as imatinib and dasatinib and ponatinib, and that these can persist through treatment and are often the source of relapse. And these cells are present at a very low number. The TKIs kind of keep them, for the most part, what's called quiescent, so they're kind of sleeping within the bone marrow, if you like, and then sometimes something changes within the cell and then it kind of wakes up and starts to proliferate. So we think that's probably the main reason for relapse, and that's part of the reason for running the taster study, which I told you about earlier, it's identified drugs that target specific pathways within these stem cells that we combine with TKIs to try and get rid of all the stem cells within the bone marrow. Do we have any other questions from the floor? Sandy?
It's just a few points. I'll take this. I know it's anecdotal. It's from the users of our discussion forum. Several of them now are talking about, when you just mentioned quiescent stem cells, and what they're doing is going on a 3-day fast, which then apparently stimulates your body to make more cells, and then going back onto, they're on their TKI. So the theory amongst these few patients that are experimenting with this is that the fast brings out more stem cells being made in the bone marrow. The TKI is there, it's then present, and then it'll hit them as they come out of that quiescent phase. So I'm not asking you to say anything about them. I'm just saying this is the discussions that are happening.
I would be extremely concerned about people doing that.
Fasting.
Doing the fasting for a couple of reasons. First, there's no evidence that we have that is going to reduce the number of CML stem cells. Second, it's probably going to affect the levels of your drugs and increase your side effects, because some days you're taking your drugs and you're fasting, some days you're taking your drugs and you're not. I think you need to be really cautious if you're one of the people taking that approach.
I will say these are American patients, and so they're very proactive in all this sort of stuff. The other point I wanted to bring up was also this same group of patients who are experimenting with dose de-escalation, and so they're particularly on dasatinib, and they're finding that their PCRs are going down the lower amount of drug they take. So they're going, these are good responders, by the way. These are in molecular remission for some years. And they've reduced their dose from 100 to 50 for some months, and then to 20. And they're finding when they get down to 20, their PCRs are, just putting it out there, Richard, I don't know what.
The PCRs are going up? Or
going down.
Going down.
So
how interesting.
Less is more.
Could be.
I think don't do this at home.
No, don't do it. These are all doing it with their doctors.
As you say, it's anecdote, and it would be really nice to look at that in a more thorough way. It's not quite the same thing, but the Russian sort of approach that I mentioned of it isn't cutting the dose, it's cutting the number of days per week that you have the dose, which isn't the same, of course, is a kind of way of looking at that. The trouble is we don't really have good science on which to base this sort of strategy, and it is a little bit like cookery. Put a bit more of that in or a bit less of that, and trial and error, and the science doesn't really help us. And in terms of your fasting, did you mean stopping the drug for 3 days?
No.
Just stopping
going
eating
on a food fast.
I see, yeah.
So just drinking water.
I don't think that's...
It's just the discussions there.
Underpinned by science, let's say.
Yeah.
I think Alistair had a question.
Thanks. As I said in my talk, I at one stage worked for the Forensic Science Service, and one of the things I did for a couple of years was to run the toxicology teams. And about 3 years ago, I went to a conference on the regulatory regimes in toxicology, and found a professor from King's, Bob Flanagan, presenting a paper on blood concentrations of imatinib, which rather surprised me because I wasn't expecting to see it. But that research, as I understood it, showed that for a standard 400 milligram dose of imatinib, there were significant variations in the blood levels. I wondered if the panel had any thoughts about any correlation between those blood levels from the standard dose and either the efficacy of the drugs or the side effects.
Yeah, so there was a big interest in this some years ago, and we were a little bit caught up in it, but the group in Bordeaux were really hot on this, of measuring blood levels and saying, well, your blood level's a bit low, put the dose up. The trouble is, as you've sort of implied in what you just said, if you take 100 people and they're diligently taking 400 milligrams and you take a sample an hour later or 4 hours later at the Cmax, I think you probably know what Cmax is. So this is when the maximum concentration's in the blood. You will find a variation. And statistically, the people with the higher levels have tended to do better at a month of follow-up and at a year of follow-up. But it's statistics. And that doesn't mean that people with low levels are doomed. And it doesn't mean that people with high levels are going to live forever. Of course not. And so it's not very useful in the clinic. And the other problem is that you really have to take that sample bang on the 4-hour mark, or was it 1 hour?
24.
No, the Cmax.
Oh, that's
the
dasatinib.
Cmax. No, the Cmax. So it's the 4 hour. And yes, Dragon is right in saying that you can't measure dasatinib in the same way, because by the trough level, the 24-hour level, it's disappeared. And the same's true of ponatinib. So as a clinical tool for everyday use, it's useless. The only time I've ever found it useful is firstly to test whether someone's actually taking their tablets, which is very naughty and underhand. But more seriously, there are major interactions with anti-epileptic drugs. So where people are taking their tablets because they're handicapped and in some sort of environment where you know the drug is being given, but there's a lot of anti-epileptic medication, it can be useful to make sure that the interaction is such that the patient's still receiving enough imatinib or whatever. So that's about the only use I would think.
The other indications that we've taken it for are people at extremes of body weight, so either very heavy people or very light people where they might have a very high or a very low level, or people with different ethnic backgrounds because they have different liver enzymes, so different capabilities and different rates of metabolizing the drugs. And certainly people from Southeast Asia often need a reduced dose of drug because of side effects, because they seem to build up much higher levels. So those would be other indications where we might test a level, but it's very
But I think
unusual.
we're all saying don't do the plasma levels because they're not of benefit, and if you have a side effect, you have your PCR and you can adjust and you go on the patient. So I really don't think that plasma levels are of any use whatsoever. Apologies to King's Path.
Do we have any more questions from the floor?
First of all, I'd just like to say thanks very much to everyone for today. I was at the last conference and I've learned so much more at this one. You think you know it all, you're never going to get it there. But given that the medication and the drugs are working really well, do you think there's any value on us now looking at giving the long-term support for people? Psychologically, we need to be looking at things a wee bit differently. I know the consultants don't have time in clinics, the clinical nurses don't have that time. And could that have an effect on people taking or not taking their medication?
I think that's really valid. I think there's no doubt CML has huge psychological aspects to it. It's much more complex a disorder to live with than it might appear at face value when it just appears to be such a success story, because it doesn't feel like a success story day to day for an awful lot of people. And I think we are trying to be mindful more of a holistic approach and trying to really explore why people might be struggling in different ways. I think the NHS is improving things like its access to counselling and is aware that access to allied therapies, yoga, mindfulness, all these other aspects can be extremely helpful. And we are trying to look at ways of streamlining some of the clinic time for people who are stable, perhaps can be monitored at home. In Leeds, we do some monitoring of people sending bloods in from home, which does give us more time in the clinic for people who need to maybe talk through other issues around it. But I think we're more and more aware that for people where it's not plain sailing, that investing time and this mutual dialogue, I think we are getting a little better at open talking, plain speaking, and listening. And I think I think patients generally feel that they can tell us more and be a bit more open about days when they don't take their tablets or why they don't. And I think, it's a cliche, but it's this journey that we're taking together, and I think that is improving.
So I would say that you should all have a specialist nurse And your specialist nurse is your link. And if you don't have a specialist nurse, you should ask, why don't you have a specialist nurse? And she is your link to your physician, and they are invaluable.
Any final points? Could we just use the microphone, because it's for the people listening online.
Shall I just speak? Can you hear me? No? Okay. What I'm wondering is, if there's some way of measuring human performance, something silly like walking up a hill in 10 minutes, and you look at the effect after a diagnosis of CML or after taking the drugs, is a reduction in performance expected? Is there a logical reason why somebody would perform less well after a diagnosis than before?
It's a very good question, and I did skim through a couple of slides which might have been relevant to what you've just asked. One of the problems is, I'm not going to ask you your age, but dare I say you're not 21 and you're not 103.
No,
so
that's correct.
your performance expectations, never mind CML, will be different to if you're 21 or 103. So you have to have age-specific performance to know what you're, as it were, supposed to be. So one way around that is to say, well, has your performance got worse because you're on a drug now, or because of the diagnosis in a holistic way?
Yes, that's my situation. I swim.
Yes.
And a year ago, I was swimming 100 lengths in an hour.
Yep.
And then slowly I noticed it was reducing.
Yep.
And then after, I've only been diagnosed for about 3 months now, but I feel I'm down to 70 now, so my performance has dropped from 100 to 70.
I might be
I'm
able
sure
to partly answer that, actually. I can probably slightly answer this, because there was a talk about it at the recent CML meeting for physicians. So there was a group from, I think it was Vienna, had taken muscle biopsies from patients on imatinib, and then they looked at their exercise tolerance on imatinib and after they stopped. And what they saw for the muscle on imatinib, that they saw early fatigue with the muscle, and then it was slower to recover at the end of exercise. So that kind of fits with what you're saying, that
Yes.
they could still do some of the exercise, but they got tired more quickly, then took longer to recover.
Yes, so it could be a little bit more, it's probably age, but it could be a little bit more than that.
Yes.
Yeah.
So
Thank you for your
there's
help.
definite evidence for that. It's not even published yet. It's just being talked about at meetings.
Could I ask a question related to that? Prior to my diagnosis, I was a runner, not a fantastically good runner, but a runner nonetheless. I gave up running because I needed a new hip, and it was at the point of my pre-op assessment for the hip replacement they diagnosed my CML. I'm now on, I'm 4 years post-diagnosis, and I'm on dasatinib. And I tried to resume running this summer and struggled hugely with shortness of breath. Is there any hope you can give me that that might improve? Now, my dasatinib dose has been recently, in agreement with my consultant, reduced from 100 down to 50. But I'm desperate to get back to some decent cardiovascular exercise, and running is the thing I want to do. I'm not a swimmer.
Breathlessness on dasatinib should be investigated separately. So you need to have the various investigations, including an echocardiogram, lung function test, perhaps respiratory referral, and also the pulmonary arterial hypertension that was mentioned, that should be factored into the side effects. So it needs to be taken seriously, more seriously than fatigue on exercise. But breathlessness on dasatinib is a serious issue that we need to look into.
I probably didn't mention that I did have a pleural effusion in 2016, and I stopped the drug for 2 months and recovered, and then restarted the drug on a lower dose. I don't notice it on a daily basis, apart from going up 2 flights of stairs and then trying to run. But in ordinary day-to-day activity, I'm not breathless. But thank you.
Have you had a repeat chest X-ray?
I had a number of repeat chest X-rays at the time. Yeah, thank you.
But the issue of pulmonary hypertension can be a little more hidden. This is the higher pressure in the arteries to the lungs. It's not something that it shows up in echocardiogram, as Dragana said, but not in chest X-rays or lung function tests. So it may not have been specifically looked for.
And thank you, because that's not something I was aware of in the past,
Yeah.
and I will bring that up with
Yeah.
my consultant at my next appointment. So thank you.
We've got one final question at the front, and then we'll wrap up.
Hi, I mean, it's probably a little bit of an odd question, this one. Has there been any studies done or any evidence that the DNA change of the Philadelphia chromosome has anything to do with any previous existing infections that you may have had, like Lyme disease or Epstein-Barr or anything like that? Can that cause that DNA damage?
There's no evidence to suggest that viral infections or any other infections lead to the development of the Philadelphia chromosome. Okay, so I think we'll stop there and close the meeting. I'd like to thank all my co-speakers for coming and giving of their time, and thank you for staying to the end of the meeting. I'm hoping to be able to make the slides available in due course, in which case we'll let you know via CML support where to find them. And thanks very much for coming, and I'll close the meeting now. Thank you.
And thanks very much to Professor Copeland for putting the meeting together, because it may not be known, but she's done all the work in organising the meeting and getting people like me motivated.